atrial fibrillation. The first speaker needs no introduction, so it's a great pleasure to introduce John Cam, who will talk to us on death and morbidity in anticoagulated AF patients. John.
Thank you very much, Greg, and good morning, everybody. You've had a long time to look at my competing interests. So long, I think that I do not need to show this slide again for the next 25 presentations at least. Anyway, they are what may conflict me. I'm going to talk about, to this title at least, death morbidity in anticoagulated patients. The usual issues that are discussed are death, stroke, both ischemic and hemorrhagic, and major bleeding. And I will stick largely to those things. 10 minutes is not very long to talk about all of this, and I'll try and restrict myself to some current registry data. So let me start with something from the Orbit registry. This registry is in the United States only, and this slide refers to patients, all of whom had a CHA DS VASc score of 2 or more. Down the left-hand side, we can see the outcomes, and we see the raw data for patients not on oral anticoagulants and on oral anticoagulants, an adjusted hazard ratio, an unadjusted hazard ratio, and adjusted hazard ratio. I think that it's very important that we note from the outset that death is the major factor that seems to be reduced by anticoagulation. Of course, bleeding is increased, and stroke and other forms of emboli are reduced, but you can see in this database, at least, this was not even a significant reduction, but there was a large reduction in overall mortality. And this is a theme that I think we should return to and should consider. The question, I think, is why do we have a large reduction in mortality? Is it because the quality of the adjustment is not very good and we're not comparing like with like, anticoagulated to non-anticoagulated? Is it instead that anticoagulating patients is an index of good quality of care? Or is it something that anticoagulants do in addition to reducing stroke that improves the mortality? So let's have a look at another set of data, this time from the GARFIELD registry. And now we're not looking at anticoagulated versus not anticoagulated, but looking instead at good anticoagulation versus poor anticoagulation. Now we're only looking at mortality. It happens to be divided into the first 4 months, etc. But here are the total figures at the bottom. And we can see that there is a really major difference between the mortality figures for those who are not well anticoagulated compared with those who are well anticoagulated. The same question comes, but here at least we have an index of not very good care in terms of the quality of anticoagulation. Now let me turn to some more data from the GARFIELD registry, and I'll show a good deal of this simply because most of you have not seen this before, but it's not in some senses novel because we've had this kind of information previously. If we look at this slide, we can see the mortality divided into the first month mortality, months 2 to 4, and months 5 to 24. And we see, at least in month 1, that cardiovascular deaths far outweigh non-cardiovascular deaths, and of those deaths, the single largest component is congestive heart failure. As we continue to follow patients, we can see that the ratio between cardiovascular deaths and non-cardiovascular deaths slowly becomes more or less 1-to-1, or if anything, a slight excess of non-cardiovascular mortality in these patients. And of course, this largely reflects the fact that it is essentially an elderly population. We can see that of the cardiovascular deaths, heart failure is the most common. Myocardial infarction and sudden death and ischemic stroke are relatively small components, particularly in the longer term, following patients up to, for example, 2 years. Now I'm turning to discuss cause of death in a little more detail using data from the XANTUS registry. The XANTUS registry is approximately 7,000 patients who are followed for 1 year, all of whom are taking rivaroxaban. And this is the adjudicated deaths in XANTUS, and there are not many registries that have fully adjudicated, centrally adjudicated deaths. So there were only 118 deaths out of these 7,000 odd patients who were followed for 1 year, and you can see that cardiovascular deaths were just over 40% of the total, and of those, half were due to heart failure. Only 20% of the patients who entered the XANTUS registry had heart failure at baseline. You can see that sudden death also contributes about 10% towards the death rate in this population of patients, but non-hemorrhagic stroke is only about 3 to 4% of mortality in this group. Intracranial bleeding, of course, becomes very important in an anticoagulated population, and that's about 6% of the total. And one other comment, cancer deaths in any elderly population will also be an important component, and you can see that they constitute 20% in this registry. Now back to GARFIELD. We're looking now at mortality over the first 200 days. All patients are in this top left-hand panel, and you can see that the mortality appears, when we look at it over this duration, to be fairly linear if we look at all patients. The total mortality, as you can see, is going up to about 3% in the first 200 days. You can see about half of that is cardiovascular, and of the cardiovascular causes, heart failure is the most common. If we look at patients who have been enrolled following a myocardial infarction, not acutely following a myocardial infarction, but sometime in the past, we see that the death rate is far higher. We see that most of it is cardiovascular, and some of it is specifically due to myocardial infarction, but it's only a small proportion. If we look at patients who are recruited and have a baseline severe chronic kidney disease, we see again that the mortality is again much higher, that cardiovascular is now only about half of this mortality, but heart failure is a large component. It's only when we come to looking at patients who were recruited to the registry having had in the past a stroke that we see that stroke rivals heart failure or myocardial infarction, ischemic heart disease in terms of mortality. If we look at these data by inspecting the hazard ratios, I've just chosen two groups, a group with myocardial infarction in their history and a group of patients who are 80 years of age or more. We can see now, looking at all-cause mortality and cardiovascular death, stroke and major bleeding, that mortality changes. Of course, in the elderly patients, there's a larger risk of all-cause death compared with cardiovascular death, and the reverse is true in patients who are recruited with myocardial infarction. Chronic kidney disease is more or less in the middle of this group. Now, I've shown you some plots of mortality over time, but here I'm trying specifically to look at early versus later mortality. And you can see the rate ratio, which is essentially the deaths, in this case, in the first months of follow-up, compared with the average long-term death rate. And you can see that in the first month of follow-up, these are patients recruited essentially with new AF, and within 6 weeks of diagnosis, we can see that the rate ratio for mortality is much higher in the first month, higher in the second to fourth month, and then more or less comes down to the steady state or linear extrapolation of death. If we look at some of the qualities or characteristics of these patients, we can see that previous stroke is associated with a high death rate, and many of these strokes were presenting characteristics of the patients who were then started on anticoagulants. So we can see that early mortality occurs particularly following patients who have had a stroke, and interestingly, early mortality is more common in young patients less than 65 years of age. Haven't actually looked into why this is yet, but I suspect that it's patients who present, for example, with carcinoma of the lung or acute pulmonary problems or something of that sort, who develop atrial fibrillation in the context of a serious illness. Now, looking at not only mortality, but also looking at stroke and major bleeding, we see that all of these factors are more common in the first few months of follow-up after presentation with atrial fibrillation than they are after the first 4 months. Now, I'd like to turn to thinking about stroke risk, major bleeding, and mortality in the context of the guidelines that we currently operate to. You'll remember that the ESC issued guidelines in 2012, for example, and 2016 just recently. And both guidelines agreed that we wouldn't anticoagulate or recommend anticoagulation to men with a CHA DS VASc score of 0 or women with a CHA DS VASc score of 1. Currently, the 2016 guidelines recommend anticoagulation for men with a score of 2 or more or women with a score of 3 or more. The previous guidelines recommended 2 or more in men, 2 or more in women. The one group that anticoagulation is no longer recommended in but is considered in is a group of women with a CHA DS VASc score of 2. Now, I'd just like to show you 3 slides that look firstly at stroke and systemic embolism, the next one will look at bleeding, and the next one at mortality. And I've arranged these risk groups along the horizontal. So you see to the left patients who we wouldn't recommend anticoagulation under any circumstances. To the right, the current guideline for recommendation, the previous guideline for recommendation, the group that's missed out here from being strongly recommended, and then these are groups where anticoagulation can be considered. And we see, if we look at these data, that there are patients who've been anticoagulated in blue and not anticoagulated in orange, and I should point out that the event rate is very small on these groups towards the left, very much higher in the groups towards the right, which of course one would expect. But you see there's a clear advantage in terms of stroke reduction for the groups that are recommended in either present or current, the present ones or the previous guidelines from anticoagulation, and that this is not present in women with a CHA DS VASc score of 2 in this data set, and certainly it is not present in the group where we do not recommend anticoagulation. Of course, the event rate's very tiny here, and I don't think that this particular direction is of any particular importance. If we now look at major bleeding, however, we see some pretty consistent results. That major bleeding, of course, is going to be much more common in anticoagulated patients, no matter which risk group we're looking at. We see, however, that the major bleeding rate is multiplied by 3 or 4 times in these relatively low risk groups, and is only doubled at most in the groups who have a good indication for anticoagulation. And finally, let's look again at mortality. And here we can see that there is no advantage in terms of mortality for any of this group that we shouldn't anticoagulate or where we might consider anticoagulation. but that there is a clear advantage in terms of mortality with anticoagulation in these two groups from the various guidelines that have been recommended for anticoagulation. So I'd like to conclude by saying that severe AF outcomes occur much more commonly shortly after the onset of atrial fibrillation, that high baseline risk characteristics are obviously associated with higher rates of major outcomes, that anticoagulation increases bleeding and decreases stroke and mortality in patients with underlying cardiovascular mortality, in other words, high CHA DVASc scores, for example, but only increases bleeding risk in patients at low risk of stroke, that the reduction in mortality is greater than the reduction of stroke in anticoagulated patients, and I'd like us to think why that might be. And lastly, that the cause of death in AF patients is very dependent on the baseline characteristics. Thank you very much.
Thank you very much, John. We move on straight to the next presentation, and it's a great pleasure to introduce Harry Hemingway from the Fire Institute in London, who will tell us about